Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 274 of our pharmacotherapy series, which majors in essential hypertension. The first question reads, DTC is a 44-year-old black man who presents to his primary care provider concerned about high blood pressure. At an employee health screening last month, he was told he had hypertension. His medical history is significant for allergic rhinitis. His BP was 144 systolic 84 diastolic and 146 systolic 86 diastolic last year during an employee health screening at work. DTC's father had hypertension and died of an MI at age 54. His mother had diabetes and hypertension and died of a stroke at age 68. DTC smokes 1 pack per day of cigarettes and thinks his BP is high because of job-related stress. He does not believe that he really has hypertension. DTC does not engage in any regular exercise and does not restrict his diet in any way, although he knows he should lose weight. Physical examination shows he is 175 centimeters tall, weighs 108 kilograms. His body mass index 35.2 kilograms per meter squared. BP is 148 systolic 88 diastolic as measured on the left arm and 146 systolic 86 diastolic in the right arm while sitting, and heart rate is 80 beats per minute. 6 months ago, his BP values were 152 systolic 88 diastolic and 150 systolic 84 diastolic when he was seen by his primary care provider for allergic rhinitis. Fundoscopic examination reveals mild arterial narrowing and arteriovenous nicking, with no exudates or hemorrhages. The other physical examination findings are essentially normal. DTC's fasting laboratory serum values are as follows. Blood urea nitrogen is 24 mg per deciliter. Creatinine is 1.0 mg per deciliter. Glucose levels are 105 mg per deciliter. Potassium levels are 4.4 milliequivalents per liter. Uric acid levels are 6.5 mg per deciliter. Total cholesterol is 196 mg per deciliter. Low-density lipoprotein cholesterol (LDL-C) is 141 mg per deciliter. High-density lipoprotein cholesterol (HDL-C) is 32 mg per deciliter. Triglycerides are 170 mg per deciliter. An electrocardiogram is normal except for left ventricular hypertrophy (LVH). So my question to you is, why does DTC have hypertension? DTC has hypertension. He has had elevated BP values, measured in clinical environments, and meets the diagnostic criteria for hypertension because 2 or more of his BP measurements are elevated on separate days. The next question reads, what is the proper assessment of DTC's BP? DTC has essential hypertension, therefore the exact cause is not known. He has several characteristics, e.g., family history of hypertension and obesity, that may have increased his chance of developing hypertension. Race and sex also influence the prevalence of hypertension. Across all age groups, blacks have a higher prevalence of hypertension than do whites and Hispanics. Similar to other forms of cardiovascular disease, hypertension is more severe, more likely to include hypertension-associated complications, and occurs at an earlier age in black patients. The next question reads, which hypertension-associated complications are present in DTC? A complete physical examination to evaluate hypertension-associated complications includes examination of the optic fundi, auscultation for carotid, abdominal, and femoral brutes, palpation of the thyroid gland, heart and lung examination, abdominal examination for enlarged kidney, masses, and abnormal aortic pulsation, lower extremity palpation for edema and pulses, and neurologic assessment. Routine laboratory assessment after diagnosis should include the following: ECG, urinalysis, fasting glucose, hematocrit, serum potassium, creatinine, and calcium, and a fasting lipid panel. Optional testing may include measurement of urinary albumin excretion or albumin to creatinine ratio, or additional tests specific for secondary causes if suspected. DTC does not yet have hypertension-associated complications. He is exhibiting early signs, however, based on his physical examination that, if left untreated, will likely develop into such complications. These early signs have likely evolved from his long-standing, poorly controlled hypertension. DTC's ECG revealed left ventricular hypertrophy, indicating early cardiac damage. Although the gold standard for confirming left ventricular hypertrophy is echocardiography, this confirmatory procedure is not necessary unless symptoms are present indicating that left ventricular hypertrophy has progressed to left ventricular dysfunction, e.g., peripheral edema and shortness of breath. His fundoscopic examination reveals mild arterial narrowing and arteriovenous nicking, which are early signs of retinopathy and atherosclerosis. DTC's serum creatinine is normal, ruling out overt chronic kidney disease. Additional testing for microalbuminuria is needed, however, to confirm that he does not have early-stage kidney disease. The next question reads, what other forms of hypertension-associated complications is DTC at risk for? Hypertension adversely affects many organ systems, including the heart, brain, kidneys, peripheral circulation, and eyes. Damage to these systems resulting from hypertension is termed hypertension-associated complications, target organ damage, or cardiovascular disease. There are often misconceptions about the terms cardiovascular disease and coronary artery disease. Cardiovascular disease encompasses the broad scope of all forms of hypertension-associated complications. Coronary artery disease is simply a subset of cardiovascular disease and refers specifically to disease related to the coronary vasculature, including ischemic heart disease and MI. Hypertension-associated complications and major risk factors for developing such complications should be assessed by a thorough patient history, a complete physical examination, and laboratory evaluation. Hypertension can affect the heart either indirectly, by promoting atherosclerotic changes, or directly, via pressure-related effects. Hypertension can promote cardiovascular disease and increase the risk for ischemic events, such as angina and MI. Antihypertensive therapy has been shown to reduce the risk of these coronary events. Hypertension also promotes the development of LVH, which is a myocardial, cellular change, not an arterial change. These two conditions often coexist, however. It is commonly believed that LVH is a compensatory mechanism of the heart in response to the increased resistance caused by elevated BP. LVH is a strong and independent risk factor for coronary artery disease, left ventricular dysfunction, and arrhythmia. LVH does not indicate the presence of left ventricular dysfunction, but is a risk for progression to left ventricular dysfunction, which is considered a hypertension-associated complication. This may be caused by ischemia, excessive LVH, or pressure overload. Ultimately, left ventricular dysfunction results in a decreased ability to contract, that is, systolic dysfunction. Hypertension is one of the most frequent causes of cerebrovascular disease. Cerebrovascular signs can manifest as transient ischemic attacks, ischemic strokes, multiple cerebral infarcts, and hemorrhages. Residual functional deficits caused by stroke are among the most devastating forms of hypertension-associated complications. Clinical trials have demonstrated that antihypertensive therapy can significantly reduce the risk of both initial and recurrent stroke. A sudden, prolonged increase in BP can also cause hypertensive encephalopathy, which is classified as a hypertensive emergency. The glomerular filtration rate is used to estimate kidney function, which declines with aging. This rate of decline is greatly accelerated by hypertension. Hypertension is associated with nephrosclerosis, which is caused by increased intraglomerular pressure. Chronic kidney disease, whether mild or severe, can progress to kidney failure, that is, stage 5 chronic kidney disease, and the need for dialysis. Studies have demonstrated that controlling hypertension is the most important strategy to slow the rate of kidney function decline, but it may not be entirely effective in slowing the progression of renal impairment in all patients. Chronic kidney disease is staged based on estimated glomerular filtration rate values. Stage 3 chronic kidney disease, that is moderate, is defined as a glomerular filtration rate 30 to 59 ml per minute per 1.73 meters squared. Stage 4 chronic kidney disease, that is severe, is 15 to 29 ml per minute per 1.73 meters squared, and stage 5, that is kidney failure, is less than 15 ml per minute per 1.73 meters squared, or the requirement of dialysis. In hypertension, stage 3 chronic kidney disease or worse is considered a hypertension-associated complication. An estimated glomerular filtration rate of less than 60 ml per minute per 1.73 meters squared corresponds approximately to a serum creatinine concentration of greater than 1.5 mg per deciliter in an average man and greater than 1.3 mg per deciliter in an average woman. The presence of persistent albuminuria, that is more than 300 mg albumin in a 24-hour urine collection or 200 mg albumin per gram creatinine on a spot urine measurement, also indicates significant chronic kidney disease. Peripheral arterial disease, a non-coronary form of atherosclerotic vascular disease, is considered a hypertension-associated complication. It is equivalent in cardiovascular risk to coronary heart disease. Risk factor reduction, BP control, and antiplatelet agent or agents are needed to decrease progression. Complications of peripheral arterial disease can include infection and necrosis, which in some cases require revascularization procedures or extremity amputation. Hypertension causes retinopathies that can progress to blindness. Retinopathy is evaluated according to the Keith-Wagoner and Barker fundoscopic classification system. Grade 1 is characterized by narrowing of the arterial diameter, indicating vasoconstriction. Arteriovenous nicking is the hallmark of Grade 2, indicating atherosclerosis. Long-standing, untreated hypertension can cause cotton wool exudates and flame hemorrhages. Grade 3. In severe cases, e.g., hypertensive emergency, papilledema occurs, and this is classified as Grade 4. The next question reads, which major cardiovascular risk factors are present in DTC? Hypertension is one of 9 major cardiovascular risk factors. These are not risk factors for developing hypertension, rather, they increase the risk of hypertension-associated complications. DTC has multiple cardiovascular risk factors: smoking, dyslipidemia, family history of premature coronary heart disease in a first-degree relative, father, hypertension, obesity, and physical inactivity. DTC is a primary prevention patient because he does not yet have any hypertension-associated complications. He has multiple major cardiovascular risk factors, so controlling his BP is of paramount importance to reduce the risk of developing hypertension-associated complications. The JNC8 guidelines, considered the gold standard for treatment, recommend a BP goal of less than 140 systolic 90 diastolic for DTC because he is a primary prevention patient less than 60 years of age. Many of DTC's risk factors are modifiable. He is a smoker and this significantly increases his cardiovascular risk and may reduce the efficacy of antihypertensive therapy. Smoking cessation may not independently lower DTC's BP, but it will decrease his overall risk of cardiovascular disease. DTC is obese based on his BMI. His lack of physical activity and dietary patterns have likely contributed to his obesity. A more focused patient interview on diet and exercise would be helpful to reinforce the assumption that he has a sedentary lifestyle. DTC's dyslipidemia increases his cardiovascular risk, and lipid-lowering therapy should be considered to further decrease the risk of cardiovascular disease. Advanced age is considered a major cardiovascular risk factor. Although coronary heart disease in the elderly is not considered premature, increasing age increases the risk of hypertension-associated complications. Premenopausal women are at low risk for cardiovascular disease. However, cardiovascular risk in women increases significantly after menopause, similar to the increased risk in men. Therefore, cutoff values for age as a risk factor in men and women are separated by 10 years, that is above 55 years for men, and above 65 years for women. At age 50, DTC does not yet have this risk factor. The next question reads, what is DTC's BP goal? The overarching goal of treating hypertension is to lower hypertension-associated complications. Control of BP is the most feasible clinical endpoint to guide therapy and should be viewed as a surrogate for attaining this goal. DTC's goal BP is less than 140 systolic 90 diastolic according to JNC8. The next question reads, what are the goals of treating DTC? Pharmacotherapy principles to achieve these goals include selecting a treatment regimen with antihypertensive agent or agents that reduces risk of cardiovascular events, complemented by appropriate lifestyle modifications. The next question reads, what patient education should be provided to DTC regarding his hypertension? Patient education is needed to ensure that DTC understands his disease and its complications. This should comprehensively include information on disease, treatment, adherence, and complications. Several approaches can be effective, but all methods should include direct communication between the clinician and the patient. Multidisciplinary approaches to disease state management in hypertension can effectively use a team of different clinicians, e.g., physicians, nurse practitioners, physician assistants, and pharmacists. Providing face-to-face education is most common, but the key components in patient education can be delivered via indirect interactions, e.g., via telephone. Education should be tailored to the patient's specific needs. For example, some patients are able to comprehend the importance of achieving controlled BP by reading written materials, whereas others understand this only after implementing self-BP monitoring. The patient education process must be continuous throughout the duration of therapy. Not all aspects need to be discussed during each clinical interaction. Careful selection of both written and verbal information should be considered so that patients are not overwhelmed or intimidated. National Heart, Lung, and Blood Institute patient education materials are available at http://www.nhlbi.nih.gov/health/public/heart/index.htm/hbp. It is important that clinicians review all materials provided to patients to identify the source of information, assess ease of reading, and identify omitted information and sources of confusion or anxiety, e.g., drug side effects. Patients such as DTC often incorrectly explain BP elevation as stress-related. Although certain patients, e.g., those with white coat hypertension, may have BP that is more highly reactive, most patients with essential hypertension will have an elevated BP regardless of their stress level. DTC should be informed about the cause of his disease and the lack of correlation between stress or symptoms and high BP. Importantly, DTC needs to realize that elevated BP is almost always asymptomatic and that it can cause serious long-term complications. It is essential that he understand the chronic nature of hypertension and the need for long-term therapy. Otherwise, he may adhere to his treatment only when he feels his BP is high, or during stressful events. Some patients believe they can control their BP by stress management rather than with antihypertensive drug therapy and lifestyle modifications. Controlled trials have not consistently proven that stress management is beneficial in treating hypertension. It is important to determine the patient's health beliefs and attitudes and to provide education about the etiology and management of hypertension to promote BP control. Another common myth patients believe is that treating hypertension commonly leads to fatigue, lethargy, and sexual dysfunction. This misconception can compromise adherence and be a limiting factor in appropriate management. Clinical trials have repeatedly reported that quality of life is better with active medication than with placebo. Data have indicated that as many as 27% of men with hypertension have erectile dysfunction. Although many patients believe this to be a medication-related side effect and that incidence rates vary among antihypertensive agents and classes, erectile dysfunction is likely caused by penile arterial changes, probably atherosclerosis, which is related to uncontrolled or untreated hypertension. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 275.